Okay, now we are going to be explaining the ventricular system. So I'll try my best to make it as easy as possible, inshallah. So let's get started first with talking about the general organization. So when we talk about the general organization, we're going to look at the brain right here, and we will see that we have two cerebral hemispheres, this hemisphere and this hemisphere. Now, it's very important to know that both hemispheres they are joined by a thick band of fibers, and this is called the corpus callosum. Now, if we take a look inside each and every hemisphere, we are going to see a hollow cavity, and this cavity will be called a ventricle, and we're going to take a look at it later on during these slides. Now, if I take a look inferior to the hemisphere, I'm going to see the brainstem, and if I look posterior to the brainstem, I'm going to see the cerebellum. And then, now let's take a look at this axial picture of the brain, the interior of the brain. Now, it's very important to note that everything we're going to describe here is going to be opposite if we're talking about the spinal cord. So, taking a look at it here, we're going to see here the gray matter. So the gray matter is outside and it's also called the cortex. Whereas if we're taking a look at the white matter here inside, we are going to see that it's formed of actually something called a highly myelinated fibers. And what do? These fibers, they basically connect different centers and nuclei. And deep within these white matter, I can see the hollow cavities that we talked about before, which are the ventricles. And I can also see this deep nuclei, and I can also see the basal ganglia. So they're also called basal ganglia or deep nuclei. Now it's very important to know that when we are mentioning the thalamus is not a part of the basal ganglia. Okay, moving on, let's talk about the coverings of the brain and the meninges. So if we take a look at the brain, we're going to see that it's formed of three layers: the dura mater, the arachnoid, and the pia mater. And between the arachnoid and the pia, I have this space here. It's called the subarachnoid space, and it's very important to note it for later on. Now, we're going to talk about the pia mater. The pia mater is also called the mother. Why is it called that? Because it's sticking to the brain surface. It's never leaving the brain surface, and it's also providing the brain surface with the vascularity. It's highly vascular, supplying the brain. So similar to the mother that's feeding its baby. It's highly vascular, never leaving its baby, and it's supplying it. And it closely follows every groove and sulcus. What does this mean? Now, if the brain is going like this, and the pie matter is sticking to the surface, it's following it. Even if it's going down through the groove, it goes down through the groove. It doesn't leave it. So if it was like this, it doesn't do this. No, it goes through the grooves. Okay. Now for the subarachnoid space that I said it's very important. It's between, again, we said the arachnoid and the pia, right? Why is it important though? Because it has the CSF, cerebrospinal fluid. Now it also has something else that's very important, which is what? The cerebral blood vessels, which are the veins and the arteries. And this subarachnoid space, it's surrounding what? The hemispheres, the cerebellum, and the spinal cord. So you can see the subarachnoid space surrounding them all, surrounding what? The hemisphere, cerebellum, and the spinal cord. Now, since we said the subarachnoid space, it has these vessels. What will happen if these vessels became damaged? We will have hemorrhage, where subarachnoid hemorrhage, and we can see it on a lumbar puncture. We know that usually it's supposed to be what? Clear. Now, if there is this damage, it's going to turn into red. We're going to see spottings on the lumbar puncture. Now, now let's talk about some dural folds. So here again, it's showing you what the two layers of the dura mater, showing you the arachnoid matter and the pie mater, which is adherent, as you can see, going with the grooves. Now, I have two types of dural folds in this picture. I have the falx cerebri and I have the tentorium cerebelli. So for the falx cerebri, you can see it's separating what? It's separating between the two hemispheres, whereas the tentorium cerebelli, it's separating what? The hemisphere from the cerebellum. Okay, so it's separating the cerebrum from the cerebellum. Now, if I take a look at an MRI, how would I know that an MRI is T1 or T2? If it's T1, it's going to appear dark. If it's T2, it's going to appear bright. How would I memorize this? WW2. So water is white. So what can I see here? White. This is white. This is white. So it's going to be white. And the subarachnoid space, as you can see, it appears as a thin line. And we said it has CSF. Now, if we have excessive CSF, it's going to appear as a thicker line. Thicker line. Okay. Now let's talk about the embryological origin of these ventricles. Now it's very important to know that our CNS is hollow. Why? Because it forms from a neural tube. Now, the neural tube has a cranial or an upper part and a caudal or a lower part. Now, this cranial part is going to expand. It will expand. When it expands, it will give me three vesicles, the forebrain, the midbrain, and the hindbrain. Whereas the caudal part down here, it will do what? It will give me the spinal cord, and the lumen of the tube itself will give me something else. So again, I have this neural tube. The upper part will become expanded into three vesicles. The lower part will be slender, more narrower, give me the spinal cord. What about the lumen, the inside of the neural tube? It will give me the ventricular system. Remember the cavities we talked about, plus the central canal of the spinal cord, not the spinal cord itself, the central canal. Now let's talk about the forebrain vesicle. This forebrain vesicle, it will give me two expansions, the telencephalon and the diencephalon. So the telencephalon here, it will give me what? The cerebral hemispheres, which consist of what we said. It has the cortex, the outside one, the white matter, and the basal ganglia. Plus the cavity of the telencephalon, it will give me the lateral cavity, the lateral ventricle. So it will give me two lateral ventricles. For the diencephalon, on the other hand, it will give me the thalamus, and the cavity of it will give me the third ventricle. So the telencephalon, the cerebral hemisphere, plus the lateral ventricle, two of the diencephalon, the thalamus, and it will give me the third ventricle. Now for the lateral ventricle to connect or communicate with the third ventricle, I will have what? I will have this foramen here, this opening here, I call it interventricular foramen of Monro, where the lateral ventricle connect to the third ventricle through it, like this. Okay, now for the midbrain vesicle, it will not expand. You see it here? It's thin. What will happen is that it will become thicker. Once it becomes thicker, it will become this area between it, it will be narrow. So it will form for me what? It will form for me something called the cerebral aqueduct of Sylvius. What does it do, this cerebral aqueduct of Sylvius? It will connect the third ventricle with the fourth ventricle. What is the fourth ventricle? We will get to know right now. So in the hindbrain vesicle here, it will form for me what? It will form for me the pons and the medulla, the remaining of the brainstem, and also the cerebellum itself for the balance, and the cavity of the hindbrain. It will do what? It will give me the fourth ventricle, and we said the third ventricle will connect with the fourth through the cerebral aqueduct of the Sylvius. But then the hindbrain, did it finish? No, it gave me the pons, the medulla, the cerebellum, and the fourth ventricle, but it will continue down as what? the central canal of the spinal cord. Okay, so moving on, let's talk about the CSF flow and the obstruction. So the CSF flow, how will it go? Like it's water, it's a fluid. Let's say I have channels like this. So how will this water flow? How will it flow? So we are going to start with the lateral ventricle. We said it's coming from where? It's coming from the till encephalon. So the lateral ventricle, it needs to go from the lateral ventricle to the third ventricle, which is coming from the diencephalon. We said it goes through the interventricular foramen of Monro. So the lateral ventricle, and it needs to go to the third ventricle through this Monro, foramen of Monro. And then it will go from the third to the fourth ventricle. The third ventricle from the diencephalon to the fourth ventricle of the hindbrain, going through the cerebral aqueduct of Sylvius, the one that we talked about coming from the midbrain passage. So, from the third ventricle, it will go to the fourth ventricle through what? This here, this aqueduct of Sylvius. So, it will go this way. Okay. Now, from the fourth ventricle, is it going to stay here? No, it needs to go out. It will go to the subarachnoid space. But will it go out like this alone? No, there will be three openings. Two of them will be median and one will be lateral. The median ones, they are called the foramen of Magendie. And one lateral one, it will be called the Lushka. So they are apertures or openings. So this will be them. As you can see here, I'm going to have two openings of the Magendie and I'm going to have one opening lateral of foramen of Lushka. So they will go, again where? They will go into the subarachnoid space by these openings. Now, we should know that the interventricular foramen of Monro and the cerebral aqueduct of Sylvius, they are narrow and they can become more narrower in other cases that will lead to the CSF obstruction. We know that they are working as a door, letting the CSF pass. So if it became narrow, it will lead to CSF obstruction. What could be the causes? For example, in a case of meningeal inflammation, in a case of Chiari malformation, in a case of tumor. Okay, for example, if I have a tumor in the anterior thalamus, what do you think it will block for me? We said the diencephalon. Okay, okay, diencephalon, give me the third ventricle, right? And diencephalon means the thalamus. If I have a tumor in the anterior thalamus, it will block what foramen here nearby to it. It will block for me the foramen of Monro, which lies directly in front of it. So this is very important to bear in mind. Okay, let's talk about the subarachnoid space and the cisterns. So here, the subarachnoid space, we said it's between the arachnoid and the pia mater. We also can call it subarachnoid cistern. Moving here, talking about the cisterns. Now, I have a cistern here between the peduncles, and I have a cistern here in front of the pons, and I have a cistern here between the cerebellum and the medulla of the brainstem, and I also have here a cistern above the cerebellum. So let's start first with the interpeduncular cistern here, this one. So this interpeduncular cistern is basically in front of the midbrain, in front or between the two peduncles of the midbrain, and it has very important circle of Willis. For the pontine cistern, it's in front of the pons from its name, and it has what? The basilar artery running in the midline. So if this is the anterior view of the pons, in the midline here, what's running is the basilar artery. Here, the superior cistern is also called the quadrigeminal cistern, and it's above the cerebellum, and it has the great vein of Galen. Very important to know that. Whereas here, the one that I said it's between the cerebellum and the medulla, okay, this is called the cerebromedullary cistern or the cisterna magna. And the magna, think of it, we're talking about something mega, something big. It's the largest cistern. Okay, the fourth ventricle, it has a roof, and this roof has basically two thin, delicate membranes. These are called the tilia cordia. Okay, these are called what? The tilia cordia. Where? In the roof of the fourth ventricle. If I have now an obstruction in the Magindi and the Lushka, these, the ones that I told you about, what will happen in this case if I have an obstruction in them? It will lead to something called non-communicating hydrocephalus. And we are going to discuss this later on, I mean. Okay? Um, Here it just showing for us this is the anterior horn of the lateral ventricle, the posterior horn of the lateral ventricle, third ventricle right here. This is a sulcus called the lateral sulcus. Here I can see both thalami, and here I can see cerebral aqueduct of Sylvius. And here are the lateral ventricles. These are C-shaped, and we are going to talk about the lateral ventricle in an upcoming slide. Again, this is the lateral ventricle, the third ventricle, the fourth ventricle. And as you can see, the lateral is C-shaped. Okay, here again the lateral ventricle. This is the interventricular foramen of Monroe, the third ventricle, cerebral aqueduct Sylvius, and the fourth ventricle. Now, let's talk about the lateral ventricle. The lateral ventricle has an anterior horn, a posterior horn, inferior horn, and the body. Okay, also, we can look at it here and see what here inside we can see the interventricular foramen of Monroe. Here I can see the fornix. Here I can see thalamus. Here I can see what? Again, the foramen of Monroe. Let's start first with talking about the ventricles themselves. These are four ventricles. They are communicating cavities. They have an ependyma, so a ventricle, they have a line of epithelial cells, and this epithelial cells called the ependymal cells. And the ependymal cells, basically, I'll explain it very briefly because we're gonna dive into it later on. Let's say, for example, I have the ependyma and I have some capillaries. They will invaginate it or go inside it like this, and then it will form for me something called the choroid plexus. Choroid plexus are the ones that produce for me the CSF. Okay, now whenever I look at an axial view in radiology, I need to see the septum pellucidum and say that it's centralized. If it's in the center or not, it's like the trachea of our brain. Okay, so basically, the septum pellucidum is what? Is a thin vertical membrane that it's between both anterior horns of the lateral ventricle. So if I take a look at it, where can I see it here? So this is the septum pellucidum. It's between both anterior horns of the right and left lateral ventricle. So I can say that it's centralized in the center, not deviated. Okay, let's talk about the body. This one, the body. So the body is found inside what? The parietal lobe, and it has the choroid plexus. And we are going to see that only what? The body and the inferior horn has the choroid plexus. So only them has the CSF production. Now, the roof of our body, it has what? The roof has this thing called the corpus callosum, which we said it connects the cerebral hemispheres. Now the floor, on the other hand, laterally on the lateral side, it has the caudate nucleus, whereas on the medial side it has the thalamus. This is the floor. So the roof we said corpus callosum, the floor laterally caudate, and medially the thalamus. And then on the medial wall, I will see what? I will see the septum pellucidum, this one, and the fornix, the septum pellucidum and the fornix. Okay, this is for the body. Again, this is for the body. I can see what here? Corpus callosum. I can see the so corpus callosum, we said it's what? In the roof. And then on the lateral wall, I can see the caudate nucleus laterally and the thalamus medially. Laterally and medially. On the medial wall, I will see the septum pellucidum and the fornix. Okay, and it has the choroid plexus. On the anterior horn, we also call it the frontal horn because it's found in the frontal lobe. Okay, it's anterior to what? The foramen of Monroe. It's anterior to the foramen of Monroe. And the lateral wall of it is found of the head of the nucleus. So it will be the head of the nucleus. If this is of the caudate nucleus. So if this is the caudate nucleus, only the head of the caudate nucleus will form the lateral wall of the anterior horn. Okay, and then the roof and the anterior wall, it will be formed of what? A part of the corpus callosum, not the entire corpus callosum, only this part, which we call it the geno of the corpus callosum. Okay, now on the posterior horn, it's found in the occipital lobe and it will be wider. What do I mean by that? Yeah, for example, this is the anterior horn, this is the posterior. You see, it's wider. This one is thinner and this one is wider. And it's found in the occipital lobe. And it is near what other part of the corpus callosum called the tapetum. So it's near the tapetum of the corpus callosum. So this is what the posterior horn. The inferior horn, on the other hand, which we said the body and the inferior only has the choroidiplexus, the inferior one is found in the temporal lobe. And very important that on the floor of it, we are going to see the hippocampus. The hippocampus looks like a lion's leg. So since we see the hippocampus, if I have any injury here, it will affect the memory, short and the long-term memory, to lead to dysfunction of it. Okay? And any type of ventricular dilation that compresses this area could also affect the memory. Here I can see the anterior horn and this is the posterior horn. Now, moving on. Before I move on, we said about mentioning the septum pellucidum that is centralized. We can also, in OSPI, comment also on the size of the ventricle, that they're normal and not dilated. They could be dilated in a case of hydrocephalus, which we're going to discuss later on. Now let's talk about the CSF physiology. Let's talk about the production, the circulation, and the drainage. So the volume of CSF is 140 to 150 ml, and the normal pressure could be from 80 to 180 millimeter per water. This is the normal one. Now the daily production, we produce CSF almost 500 milli, which could be produced, circulated, and reabsorbed multiple times per day. So we are working so hard to make sure that the CSF is well. We're doing it multiple times a day, not only once a day or one time a day. Why are we doing this? Why is the CSF so important? Because it supports the CNS. It works as a water jacket to support it. It also helps distribution of large vessels. It also regulates any type of tension if I have an intracranial tension. It also replaces the lymph. Why? Because it removes the metabolites. It does the job of the lymph. Now, how is it produced? Again, remember I talked to you about the ependymal cells, okay, which are lining the ventricles, single epithelial ependymal cells. Now, a tuft of capillaries, as I told you, it will come, and what will it do? It will invaginate, go inside the ventricular wall, and then what will happen? It will go inside, so a tuft of blood capillaries invaginate the ventricular wall, covered by the ependymal cells, and then it will form for me the choroidiplexus. The choroidiplexus, what will they do? I said it will give me the CSF. So by giving me the CSF, I'll have CSF blood barrier. It will give me the growth factor. It will give me stem cell pool and protect against any type of toxins. Now, how can we drain it? Now, after the CSF, we've seen its flow. How does it go? Where does it reach? Now it wants to go out to the venous circulation. So where will it go? It will go to the subarachnoid space, the one that we talked about. And it needs to pass either by arachnoid villi or the one that's bigger than it, which is the arachnoid granulation. And by these two, they are the door to let it go in. Once it goes in, it will go to what the superior sagittal sinus and the transverse sinus. Once it goes to these sinuses, it will act as a valve. Means it goes one way, it doesn't allow it to go the other way, go back, fall back. So what will happen here? It will go and go to the subarachnoid space. Now other small volume of it will be absorbed by the lymphatics. Now, in the case of meningitis, what will happen? In the case of meningitis or venous sinus thrombosis, these people who have these diseases, these issues, it will thicken their arachnoid villi, which will reduce the drainage. And it will, when it reduces the drainage, the CSF is going to accumulate. Think of it as like accumulating inside this area. The door is locked, it cannot go out. So it will increase for me the intracranial pressure. Okay, and it also could lead to hydrocephalus. So this is how it looks like. This is the dura mater, this is the arachnoid villi, this is the falx cerebri, the arachnoid mater, and this is the superior sagittal sinus in the falx. And this is how the arachnoid villi, it protrudes where into the superior sagittal sinus and it allows for it to go. Okay, now moving on and talking about the hydrocephalus and the intracranial pressure. Now, if I want to talk about this, I need to differentiate between two scenarios. The first scenario is when we're talking about a high volume states or low volume states. Let's talk about the first scenario. So let's say a person has increased intracranial pressure above 200. This means they have a lot of secretion. This means a lot of secretion like choroid plexus papilloma, or they have a block circulation, blockage, or no drainage. Okay, now in the babies, if it was in the babies, we know that the babies they have their what? They have their sutures. It's still not that fixed. It's not that fused. So if any increase in the pressure comes and push on it, it will bend, right? So it will lead to what? Head enlargement and bulging fontanelle. But for us as an adult who have few sutures, or when it tries to push on it, what will happen here in this case? It's fused, it's not going to move. So we will just have headache, vomiting, and the blurry vision. The other case scenario when I have low intracranial pressure, it could be because of dehydration. Someone is dehydrated, or the CSF is being leaked because of a rupture cyst, lumbar puncture, or skull base fracture. This will lead to something called orthostatic headache. Orthostatic headache means what? It means when a person is sitting or a person is standing, they will feel bad. But when a person is laying down, they will feel good about this headache. Now I have four types of hydrocephalus. Let's start with the non-communicating or obstructive one. Non-communicating means I have this area and this area and I put something between them. They're not communicating. So it's within the ventricles themselves or the foramens or the cerebral aqueduct. So the first case, it could affect what? The aqueduct of Sylvius. So if it affects the aqueduct of Sylvius, we said about it what? It connects between the third and the fourth ventricle. So when it closes here, what will happen? I will have expansion of the lateral and the third because the lateral and third are behind this aqueduct of Sylvius, so they will be affected. Okay. The second case, if the foramen of Monroe is closed, it connects between the lateral and the third. So if I close it, what will be expanded? Only the lateral. What about the Luschka and the Begindi? If I block it, what will happen? All the ventricles will be expanded because it's the end point. The second one is the communicating hydrocephalus. It's basically when the issue is in the subarachnoid space itself. And it will be like post-meningitis. If in the question came a person had meningitis before and they're having this and that symptoms, what is it communicating? The third one is called the normal pressure hydrocephalus. The problem here is that the CSF is not being absorbed. The problem is in what? Arachnoid villi. Okay. Often because of post-hemorrhage. In the question they say that the person had hemorrhage. Okay. How can we also differentiate it? It will have a triad, the three W's. So they will have wet, which is urinary incontinence. They will have wobbly, dementia, and wobbly ataxic gait, and wacky, which is dementia. Okay, so urinary incontinence, progressive dementia, and wobbly, which is ataxic gait. They're not walking straight. And why do I call it normal pressure? This means the intracranial pressure will be either normal or mildly elevated. The hydrocephalus ex vehicle here, the ventricles, they will not be enlarged. The problem here will be in the brain itself. So the brain will atrophy. The brain will atrophy. Let's say, for example, I have this brain and this ventricle, and the brain became smaller, and it's the same ventricle. It didn't change. So the ventricle will appear larger, but the problem actually is not in the ventricle. The problem is in the brain being atrophied. So here it's because of dementia, Huntington, or post-trauma. And this is how it may look like. Okay, now the last question. Here it's telling us, for example, pick which is the correct labeling. So it's telling us structure B here is the interpeduncular between the peduncles, as you can see here. It's very important to not mix between the interpeduncular cistern and the pontine cistern. The pontine will be where? Here in front of the pons itself. Okay, and do not confuse between here. This is the fourth ventricle. It's not the cisterna magna. Okay, and yeah, I hope it was clear. Thank you.